The bill is currently in Assembly Rules, and it literally sits there as we speak. It needs to be referred to the Health Committee. Hopefully they'll do that tomorrow. We got to get it out of the Health Committee before July 14th. That's the deadline. And then it goes to the Appropriations Committee, and it needs to get out of there. They take a recess until August, about August 21st, and then by September 1st, it's got to get out of the Appropriations Committee and onto the Assembly floor. And we need 2/3 vote. We need 54 Assembly members to vote for it. Then it goes back to the Senate, where because we didn't have the financing plan at the Senate, we put it back to the Senate for a 2/3 vote. And we're going to need 27 senators before September 15th. And then it goes to the governor after that. And he has a month to act. Grace?
So we're going to take questions, and to do that, if you could queue up at the floor mic, or if you're not able to stand and would like to ask a question, you can raise your hand, and Kyle will come around with a hand mic for you. Hey. All right, well, we'll start off with our first question here.
Hi, can you hear me? Oh, so I think I saw that hearing aids are covered, but my question is, both my kids have cochlear implants. Do you know if that's covered? That's very expensive.
Yes, those would be covered because our standard is, medically appropriate or medically necessary treatments. So it is intended to be comprehensive that way.
Hello, and I just want to thank you. I really appreciated the update. I'm completely behind this. I read 2 excellent articles just today. I've been following it over the months since Trump was elected, and has been trying to eliminate the what's now called Obamacare, but the Affordable Care Act. So I've been following it closely. There were 2 excellent articles that I just happened to read this morning, knowing I was coming here. They caught my attention. One was in the Daily Californian. The other was in the Los Angeles Times. And I want everyone here to know that I'm fully supportive of this, completely on board, and want to be part of the solution and help drive it through. However, in the articles I've been reading, which we can't naively sit here and think because we buy into it, everybody else does. There's a very strong contingent, that oligopoly, and with a combination of Citizens United, that is extremely invested in maintaining the status quo. So I am concerned because they're marketing this as 2 different, a $400 billion assessment of funding, a $330 assessment of funding through that Amherst study, the Nurses Association. They're also saying that Governor Brown is not really behind it because there's a deficit, there's a funding gap that he's worried about where those funds are going to come from. And yet when you listen to this presentation, it seems like a no-brainer, an obvious way with all those inefficiencies cut out of the economic system, the financial system, we would easily make up for any of the shortfalls that currently exist. I get that, I buy that, but we have to get more people saying that who are leaders within our government, not just as, I guess it starts with California, but it has to go beyond that. And so I was a little concerned. Why would Governor Jerry Brown not be immediately on board and not recognize he's been a lifer in California government? Why would he not recognize the efficiencies that can be created? And then finally, one other point I want to make is when I was invited to this, which I was deeply appreciative of being invited, however, it was called California Single Payer System. Whenever you hear Paul Ryan, whenever you hear Donald Trump, whenever you hear the Senate, majority lead, they have already packaged things with these really pretty euphemistic names that everybody who hears them thinks, oh, this is a good thing, and they make it really simple. So I love the California, Healthy California Act. That's beautiful. But let's stop calling it all these detailed other things. All it does is confuse and call people's attention to the bureaucracy. And we need to get smart with how the words we use and how we talk about things, because the other side's been outperforming us in that area for a super long time.
Well, I think that's really important, and that is our dream. That is our dream, that we stop saying single payer or Medicare for all. We say healthy California. That's really what we're trying to do. Now, when we try to describe it, the analogies come forward, like it's like Medicare for all, okay? Or a lot of the media is the one who drives the single payer moniker, as it were. And so we have to change that. And so Healthy California was chosen intentionally, precisely for that reason. So let's keep working on it. Now, Governor Brown does support, this is having just said that, Governor Brown supports single payer, but he doesn't support Healthy California, right? And so when he ran for president in '92, he ran on let's do Medicare for everybody. That was his platform. The economist who helped him design his program in '92 is the one who did the study of Healthy California. That's not a coincidence. I read that. Right? So he's asking the tough questions because he has, he's staked his reputation for his second run as governor on fiscal rectitude and proving that he's not your usual Democrats, tax and spend Democrat. Okay, he just passed a $52 billion transportation tax and an upper income tax, but okay, Governor, that's cool. Those are good things he did, but he wants, to preserve the fiscal achievements that he has made as governor. So he's concerned. Are we going to get the money from the federal government right? Is there the money to sustain the system? Those are legitimate questions. We have rigorously answered them. I think he's smart. We expect him to sign this. We expect him to be persuaded that just as he supports it in general, he can support it in California. And we're doing the individual meetings. We're working with his staff. And we obviously provided the research that we believe will be persuasive. So why is he not jumping up and down? Because he's cautious. Because he understands that, as the president has discovered, healthcare can be complicated. And we've created a very complicated system. It doesn't have to be, but it does have to be unwound. And that is going to take some real work on the part of his staff, the legislature, and all the advocates. And so he's just being cautious. That's how I would answer the question.
Thank you.
Pat?
Hi, I have a question on a question. And being a person of a certain age, I have doctors for every body part. Now, one body part in particular is my back, and I am on workers' comp. What happens to workers' comp?
It's a very interesting question because the bill mandates that we incorporate the medical portion of workers' comp within the first 2 years. At the same time, we do not want businesses to just feel like they're off the hook. So, hey, it doesn't matter if I, have a safe workplace or not. I've got all my health care is covered. So we got to preserve what's called experience rating, right? So that businesses have an incentive to maintain safety in their workplace. So that's what we got to work out. But within 2 years, it'll be covered.
Second part of the question is, do I have to pay my secondary insurance? Do I keep that?
Not your Part B. You do not have to. That Healthy California will become a Part B supply provider.
I'm talking about AARP or...
That's what I'm talking about.
Okay. Same
Those
thing.
are all Part B plans. Your AARP is a Part B plan.
Okay.
Yeah. What?
The supplement.
Yes, it pays you buy, but that plan, that supplemental plan, will be replaced by Healthy California, and the Part B will be paid by Healthy California. You will still have a deduction out of your Social Security check. That's mandated by federal law. We can't change that.
Okay.
But the other out-of-pocket spending that you do with Medicare when you buy the 20% copay or the supplemental or the Part B, that portion will be covered.
Thank you for a wonderful presentation. My question has to do with retired public employees. Now, for years, they've retired and they've moved out of state. They're no longer California citizens.
Right.
I've checked over the bill. I cannot find anything in there for retired public employees that had their insurance paid through either CalPERS or their agency. How's that going to work?
Right. So this was a question that we didn't think we could solve initially. So what we have is a provision in the bill that says that we can negotiate the coverage of retiree health benefits. Again, we have this 2-year phase-in period for things. Workers' comp, negotiating coverage of retiree health benefits, and long-term care. So we know that we can just start covering retirees in California, right? We can just say, no longer need to have a retiree health policy. Healthy California will take that over in combination with Medicare, just like everybody else. Mm-hmm. But you're right, we have this issue where people have earned a benefit in California but are no longer residents. So how do we cover them? We got to figure that out.
Yeah.
We don't know up front. Beautiful. No, thank you, I appreciate that. Now, in general, the public sector does very, very well. And that means taxpayers do very, very well. Because the gross receipts tax is not a tax on government agencies. So the amounts that they're currently paying for their employees' health care, that's part of the public contribution that we count, so they'll continue to pay that. But beyond that, going forward, they won't have increased premiums, and the employees themselves will not be paying co-insurance premiums either. So initially and over time, it's a great deal for public employees.
Okay, I want to start out by saying I totally believe in whatever you want to call it, single payer or whatever. But everybody should be able to get health care independent of how much money they have. However, I have two things. One, the number of doctors that we have. I even see, I go to Palo Alto Medical Foundation in Mountain View, and when the ACA got implemented, the impact on that facility, you could notice. You can't get appointments as soon. I mean, there aren't enough doctors. Now, this can't cure that, but along with it, I think there has to be some method of people be able to become doctors without having to be extremely wealthy.
Yes.
Now, that's a whole separate issue,
Hear, hear,
but
hear, hear.
that's going to impact the medical profession as we now have it.
Yeah.
I'm sure most of them are in favor of this. Now, but first of all, also, you've got doctors who aren't taking new patients. Their practice is full.
That's right.
All right, well, they're going to get fuller. There's going to be nobody left who will take new patients.
Yeah.
Anyway, that's
let me-
big concern I
Yeah,
have.
no, I hear you.
Okay, and the second thing is where all the funds will go into this trust. We've paid into Medicare for our working life. We're retired now. Now, the federal government's got that. They're gonna give it to us?
They'll continue to do it.
Yep, they are.
No, I'm not talking about people who are still paying into it. No. All right, there's a Medicare trust fund.
That's right.
So what's going to happen
Well, so
to the
this-
California part of that
Exactly,
trust fund?
exactly. So what happens is, surprisingly perhaps, under Medicare law, states can administer Medicare. So the monies that Medicare pays providers we'll collect through the trust fund, and we'll pay providers, and we're going to pay them the same as Medicare pays them by and large. And we're going to accept Medicare's determination of what's covered. So it is kind of, that's why I say it is like Medicare in California.
It is Medicare, California
In that
Medicare.
sense, because the rates will be based on Medicare, not identical necessarily in all cases, because we do have to address the doctor problem. The way that Medicare can pay like specialists lower is because they know there's commercial insurance out there that'll keep the specialist around, right?
Right.
Well, we have to compensate for that. So we're not going to be able to pay exactly Medicare rates, but that will be the basis. The Medicare monies will come into the trust fund, and then we'll pay the providers just like Medicare does now. But we'll be able to do it efficiently because we're paying for everybody in California.
Doesn't the federal government have to buy into that?
Yes, they do. But there is, I know.
Need
but-
I say more?
Well, no, it's a valid point. But look at it this way. First of all, we have the statutes that say, this is the law of the land, so states can do this. Secondly, you've got a waiver provision in the Affordable Care Act that they're not even trying to repeal that enables states to get all that money and use it if it's budget neutral to the feds and improves access, which obviously this does. Thirdly, if they're going to let Indiana do whatever they want, they can't just tell California no. They got to treat us the same. They may not like us, but as a legal matter, they still got to treat us the same. So we have a statutory basis to get the waiver. We have precedent. Hawaii's already got one under the Affordable Care Act. You've got language in federal law that says states can do this, and you've got the basis for equal treatment. So we really think we have a strong case. Now, I understand be skeptical, but keep in mind, the bill has a provision that the Secretary of Health and Human Services in California has to certify that there's monies there to implement the bill. And if we don't get the waivers, then we don't have the money. So, and then, I could get into it further, but there's a lot of different ways to incorporate that money. And so we're confident.
So
and back to the previous question about Governor Brown, once we get Governor Brown on board then you've got the full weight of the state government.
But it is contingent on having the funds.
Californians have the right to those federal payments, just like every other, in this case it does apply just to citizens, every other citizen of the US. So there is no way that the federal government can tell you as a Medicare recipient that you're not entitled to those Medicare benefits. So let's be clear, let's be very, very clear. When it comes to benefits and payments, we're not going to let them treat us differently, period.
Thank you.
Okay, I have 3 points. First of all, have you figured out how many jobs in the insurance industry and clerks in medical offices are going to lose their jobs?
We don't have that number yet. The economists who did the initial financing study are also experts in just transition between, in their case, fossil fuel economy and a green economy. Those same principles will be applied here. We have a provision in the bill that guarantees a just transition for anybody who loses their job as a result of this. So the bottom line is we're going to protect those workers, and we're going to have a specific program to do it.
Okay.
We haven't fully developed it yet.
Is everyone in the country who's sick going to move to California?
Only if they can afford housing in California.
We already have a large unhoused population.
Yes, but I don't think people are going to move to California to be homeless to get health care. I could be wrong.
You could be wrong. What I would like you to do is give me a simple 1-page or less document that I can use for talking with other people about this.
All right. We will do that. I would urge you to go to healthyca.org, but we definitely, now that we have this financing study and the bills moved, we do need to do that 1-page.
Most important in that is how we're paying for it,
Yeah.
because that people don't believe it can be done. I believe it can be done.
Yeah, no, I know.
Thank you.
I know. Can I just say something quickly, sir? I'm sorry. On the physician question. So, because I didn't really answer that question. Look, here's the thing. Here's the thing. When we established limits on the number of patients each nurse could take care of in California hospitals, 100,000 registered nurses either re-upped their license or came to California. Why was that? Because we improved the practice environment in a fundamental way. Because the number one issue facing nurses was short staffing. Similarly, what is the number one complaint of doctors? Insurance companies telling them what to do. We eliminate that. That is a revolutionary change in their practice environment. The issue is, under the present system, are we just going to accept that there's 36% of our state that is underinsured, so it doesn't go to the doctor when they need to, and just leave it there because, hey, we don't have enough doctors? Or we're going to transform financing and improve the practice environment and have a better shot than the present system at improving the number of doctors in California, and as you say, down the line, move monies from bureaucracy and profits to medical education, right? Graduate medical education. That's part of the transition. We're going to take those administrative jobs and move them into clinical jobs and retrain people where we can. So the whole system changes so that it is more likely, not guaranteed, but more likely to be physician-friendly, a better practice environment, swift, reliable reimbursement, clear delineation of who's in charge clinically. So we think that has a better chance of improving and dealing with the physician shortage. And so that's our theory of the case.
I have cerebral palsy with spastic diplegia. It caused while I was still in utero because a distracted driver fatally injured my mother while she was crossing the street. Okay. Because it was such a cut and dry case of wrongdoing, I was awarded a significant sum in a wrongful or personal injury suit, originally as a special needs trust back in the 1990s when it was the heyday of pre-existing conditions not being covered and things like that. It was a sum that was basically awarded in the assumption that I would not be able to get coverage. And so with Healthy California coming on the scene, that I frankly feel obligated to pay more than what I would be paying through taxes into the system. Does SB 562 have a provision for outside donations?
You know, we hadn't thought of that. You okay? You have stumped the policy director. I haven't thought of that.
Sorry,
but it's a great idea.
Couldn't hear that over the applause.
No, I was just saying you have stumped me, and no, we haven't done that. I hadn't thought of that. We hadn't thought of that, but it's a great idea.
Would you please consider it and
Absolutely.
maybe consider even the angle of making it tax deductible 501c3?
That's why I was just thinking we should set up a foundation, the Healthy California Foundation. All those in favor? Hey.
I want to say thank you so much. Your presentation is inspiring and informative, and
thank you.
I'm totally on board, already. So I am completely supportive of this. This is based on a skepticism of, someone who is, in the tech industry and is saying like, well, this sounds good. Okay, yeah, we want healthcare for everyone, but what about someone who has employer insurance under the current system? That's a very good plan, gold-plated, whatever, healthcare under their employer. Like, what would happen to that? And I actually I'm curious myself how this would address the current people who have healthcare, insurance under their employer, and it's very good. Would they lose? Would would that just remain separate? So that's a question.
That's a good question. It's a little ironic to come to Silicon Valley and have tech people tell us it can't be done. I mean, isn't that the opposite of what this is about here, right? It's like anything can be done. Cars can drive themselves, right? Okay, self-driving cars is more realistic than guaranteed health care for all. Okay, all right? So I'm not going to take that argument in Silicon Valley, okay? But on this question, yeah, it's true. I mean, look, our study showed that even if you have employer-provided insurance, you're going to spend less on health care. Now, it is possible, though, that there are some companies who will provide a family plan with no premiums and deductibles. Does anyone have one of those plans? Family coverage fully paid by your employer. Right, no copays, no deductibles, no premiums. Anybody have that plan? This is typical. They exist, but they are rare. They primarily exist actually in union plans. So we have this argument more with union members who really do have those kind of plans. I mean, they're not many, but they do. So there is probably a very small number of people, if they're paying literally nothing out of pocket, who, because they'll have the sales tax, will pay more. We don't think that's very many. It might be 5%. Because if you have any out-of-pocket costs at all, co-pays, deductibles, part of your insurance premium for your family, that's all gone under 562. Yeah. There's literally no insurance company premiums, deductibles, or co-pays. So all an individual would pay, unless you're a business owner who has gross receipts over $2 million a year, is the 2.3% sales tax. And you got to buy a lot of stuff, right, to make up for what you spend on health insurance premiums, deductibles, and co-pays. And so that's why we think virtually everyone comes out ahead. But yes, it might be 5%. Some very wealthy folks may end up paying more.
But would their health insurance still come from their employer like it does now?
No. Let me be clear.
Go away?
Yeah, the insurance companies no longer offer any policies that cover the services that Healthy California covers. So for everything, and it's comprehensive, for everything that Healthy California covers, there is no private insurance sold in California for it. So that's why I say, you want to stop dealing with insurance companies? Get your legislator to vote for 562, because they are gone. They are gone. That's the deal. Yeah. Thank you.
I'm trying to compare this to Medicare, which is the biggest single-payer program currently, and the prices. So when a person is covered by private insurance, the insurance company sets some price for services, and they also argue with doctors and hospitals about whether a treatment should be allowed. With Medicare, Medicare just pays for any treatment, and the government sets a price. And doctors and hospitals complain about that price. And with
Not really any treatment, but yes, broader way of treatments, yeah.
And then with Medicaid, which covers poor people rather than old people, the prices government pays are even less, and there are a lot of providers who just, it's not worth it to them.
Exactly.
How will the prices under Covered California be set, and what if providers aren't willing to accept that price?
Right. Well, here's the thing. In the bill, we provide for collective negotiation of prices, reimbursement rates to providers. The fiscal study that we did said that in order to save money, you're going to have to base your reimbursements on Medicare rates. That is about a 15 to 20% increase for Medi-Cal. So Medi-Cal doctors will now see a raise, substantial raise. Those doctors who have a mostly Medicare population will be pretty much the same. And those practices that are heavily private insurance will see a 22% decrease in their rates on average. However,
In their rates, you mean in their reimbursements?
yeah, in the reimbursement rates, sorry. Yeah,
Okay.
in the reimbursements, right? So Medicare is about 78% of commercial insurance on average in terms of the reimbursement rates they pay providers. So, but at the same time, they have lower costs because their billing department mostly goes away. They're not getting reviewed, their medical decisions are not being reviewed by the insurance companies, their treatments aren't being denied. So on balance, we estimate that and we talked to the California Medical Association about this, on balance, most doctors are going to be fine with Medicare rates. However, that is not true for all doctors. There are specialists who are paid under Medicare hugely less than they are under commercial insurance, and that's where the negotiations come in, where then we have to sit down with the County Medical Association or specialty organization and figure out a reimbursement rate. The whole trick in the system going forward is to balance reimbursement rates and budget and access, right, based on that, and trying to make sure that the providers still stay in California and provide services, and that we have more providers. And so I'm not going to tell you that's automatic, but we know that, for example, Sutter Health, which runs in about 22 hospitals in Northern California, have embarked upon a project to become, well, in their terms, profitable at Medicare rates. And keep in mind that most of the healthcare system is thriving under Medicare, because it is the bedrock for most of the providers in the system. So we think that is a solid basis, provided that we compensate for underpaid specialties, lower rates in rural areas, and so that's what we're going to try to do. And we estimate that will generate some number of savings as a result of lowering those rates.
Mm-hmm.
That's one of my questions. I'm basically in favor of single payer, but I do have a question. A lot of people belong to Kaiser.
Yes.
So what would happen? All these Kaiser doctors would somehow go into private practice? How would
No.
that work?
No. We're in a little debate with Kaiser. If any of you saw the health committee, and we have a different view. Kaiser says that if you eliminate our health plan, then you're going to destroy Kaiser. And kind of our bias is, since we represent about 18,000 registered nurses, that kind of what makes Kaiser Kaiser are the nurses and doctors. So we have a different view. It's not the health plan that makes Kaiser, it's the caregivers that make Kaiser. And George Halverson, the former CEO, agrees with us. That's what he thinks too. So here's the deal. The health plan in Kaiser negotiates with employers and individuals to set rates and policy. So it's a drug formulary or a set of benefits and so forth, right? That function is gone. We eliminate that function. There are no more private insurance companies setting rates with hospitals and employers and individuals. That function is gone. The health plan in that case would just deal with Healthy California Trust Fund. And they would not deal with anybody else. They'd just deal with Healthy California Trust Fund. All the stuff that the health plan does internally, coordinating care and so forth, that remains the same. They can do their internal procedure. What they can't do is generate $3 to $4 billion a year in net income in California so they can buy up facilities and expand nationally. We don't want to fund that. We think that's wasteful. They disagree. They want the health plan to still generate that kind of net income. That's their business model. We think that's an industry model. We think they should go back to their caregiver origins. We have a debate. I don't see the hundreds of Kaiser clinics and the dozens of hospitals going away. Because what we say in the bill is if you're an integrated healthcare delivery organization like Kaiser, you can still have members. You can still have your 8.5 million members. And in fact, you say you want to compete on quality. Well, what is this if not a system that takes price out of the equation and you can compete on quality? So you'll have not 8.5 million members, gee, you could have 10 million, right? But the fact is that those people are still going to be able to stay in Kaiser, and we'll even give Kaiser a break. We'll say that if you join Kaiser, you got to stay in Kaiser for a year. And we'll pay you a per person payment for every member of Kaiser from this system. And then you can decide how to allocate those resources. We think that's a good deal. They disagree. That's where it's at.
Thank you.
Hi, Michael. I'm Lynn Heidi Coper. I've been working on single payer for 20 years.
Now, we don't want to brag about that too much.
and am especially angry at one selfish person that we could have had single payer 10 years ago, and it would have spread to the rest of the country. But I'm not going to get depressed. I'm glad that you talked, because I wasn't sure after the hearing the other day when the financing was going in. So now we do need the 54. Okay, I've got a list of the Assembly Health Committee members. I usually send it out to my list because we need to lobby them first, obviously, and your own Assembly members. Because there's some that aren't on board, so we do it a lot to lobby. So if anyone wants to get an email from me, I've already made a one-sheet list. There's 15 members, and in the committees, they only need a simple majority. It's the floor that requires a 2/3. Well, you just answered one of my questions. It was about Kaiser. Because you have a total choice of doctors now, people could join Kaiser, having never been to there before. Is that right? For a year?
Once they're in for 3 months, they're in for a year, right, and they can't change. So that's the way we preserve the per person payment.
In looking at the benefits, and I saw surgical procedures, a lot of people are asking me about abortion. And I'm assuming that would be covered under the title of covering surgical services?
Yeah, well, or outpatient medical. I mean, when I say everything's covered under Medi-Cal, California currently pays for abortions for low-income people. There are some states in the federal government that does not use tax dollars to pay for abortions. We do in California, so it continues. And we're going to specify women's reproductive health services as a covered category because we get that question.
I also want to compliment Michael because I've seen him at the hearings. This guy is a walking encyclopedia. When the insurance companies were trying to finagle with some of the answers at the Health Committee, Michael had all of the statistics. You were very impressive. We're really lucky to have you.
Thank you, Lynn. Thank you.
Hi, thanks for being here. I went to the Senate Health Committee hearing like about a month ago, and I'm totally on board with single payer. I have a friend who's about to go to med school, and I'm trying to convince her that single payer is the way to go. And during the Senate Health Committee, the chair mentioned that California, like you said, has a shortage of primary care physicians, and most people go into specializations because they pay more, et cetera, et cetera. And that the other thing is that most healthcare providers are concentrated in urban areas, and there is a huge swath of middle California, which is all farmland. And I want to know, first, like, how will we be able to incentivize, first, for students to be primary care providers, and for people to not just practice in urban areas, because you can't fix the healthcare system without also dealing with the education system. And you know, like, many doctors have huge debt for a very, very long time. And so, yeah, I want to know how I can convince her.
Right. It's true. It's a lot of young doctors or a lot of med students support single payer. So I think she'll find a lot, a number of her students would encourage her to do so as well. Well, the primary problem in rural areas is that the patient population is skewed toward Medi-Cal. Because, like for example, Kevin McCarthy, who's, believe it or not, the majority leader in the US Congress, his district, 50% of the people in his district are on Medi-Cal. And that's Bakersfield, rural area. So once we raise the Medi-Cal reimbursement rates, doctors in those areas will get a significant pay raise because their patient population is so Medi-Cal. And there's a huge number of underinsured and uninsured in rural California. So rural California actually does better because now everybody has coverage, and that coverage will reimburse doctors much higher rates than most are getting now. And also for those who are getting private insurance, there'll be more patients to see. So it's true that we have a physician shortage, but it is particularly acute in rural areas. Once we equalize reimbursement rates, and that's why we can't just rely on Medicare, then we will see an incentive to relocate to those areas. The other thing we do, which is the, I guess, upside of the difference between primary and specialty, where the specialty rates are lower, the primary rates are higher. And so we'll be able to readjust in the system primary care rates so they're more attractive to young doctors to go into primary care. We can do that. What we can't do initially is change the hundreds of thousands of dollars in debt that medical students accrue, right? We can't do anything about that immediately. But there is a provision for funding graduate medical education. So in a system in California, right, where we have public universities with some of the greatest medical schools in the world, we have the ability over time, and I emphasize over time, to move some of the healthcare system resources into educating nurses and doctors in the public system. We're not doing that immediately. We're not promising to do that overnight. We believe we can improve the practice environment, we can equalize reimbursement rates, and that will address the key issues you've identified. For a doctor, a med student, she needs to decide, do I want to practice the way the insurance company tells me, or do I want to practice the way I've been educated to practice? And what kind of system will enable me to do that? Is it the present system, with the insurance companies looking over our shoulder, denying people care, creating a very costly system, or is this a better bet for my future? And we think still it's a better bet.
What's her pay under both systems? Because that's what she's going to be worried about, her pay.
Right. Well, honestly, it depends on what, because you might be in a Kaiser where you're on salary because you're in a per person payment. You might be in a rural area with a Medi-Cal population where you'll be working basically on Medicare rates, and it depends on how many patients you see. I mean, there are just a lot of factors there. So it would be hard for me to say in an individual case how much she'll make under A and B.
I mean, not a specific amount, but like, how will they compare? Like a doctor
Well, that's what I'm saying. A primary care doctor under this system will make more, and over time, you might see specialists making less. That's the general thing. And when you look at these other countries, why do these other countries spend less on healthcare? Well, number one, they control prices, and number two, they pay their physicians differently and usually less.
I thought it was going to be fee for service.
It's not, Pat asked the question, is it fee for service? It's a mixed system. Because remember, we're going to have Kaiser, where we're paying for 8.5 million people per person payments, right? We're not doing fee for service for Kaiser. Other groups can form, like community clinics, county-based healthcare consortiums. Those can also be integrated systems that we'd pay per person. Then there'll be the doctors getting Medicare. So we should respect this line. I'm sorry, I got far. Margaret, help me here. Does that answer your question, though?
Yeah, we just have a few more, we need to wrap things up, so hopefully we can get through as many questions as possible in the next 7 minutes.
Okay, well, I'm a huge supporter of single payer, and I have one suggestion, which is maybe to have some dramatic stories from doctors and nurses about how much time and money they spend fighting with insurance companies, because I know, maybe patients don't know, but they can be very dramatic about it. Secondly, as a sort of a devil's advocate question, I've had 2 doctors drop out of Medicare, not because of the reimbursement rate, because I paid them the same as they were getting, but they couldn't stand the way the paperwork was handled when it was transferred out of California down to some state, Georgia or someplace, that people kept messing up. So you would need to reassure physicians, I think, that that's not going to happen to them. And then the last thing is a big one. Nobody's talking about the long-term care provision. I carry long-term care insurance. I pay really a lot of money for long-term care because it's not a cheap thing, especially since not everybody has it. I'm sure when it's more generalized, the price will come down. So a lot for you to consider and maybe answer. Thank you.
Well, on the long-term care piece, so we mentioned the UMass Amherst study. And that did come up with a number. If you cover everybody in the present system, you are going to spend over $400 billion. But SB 562 isn't the present system. So you can save money by eliminating the insurance companies and all that administrative waste, and you can replace insurance company premiums and only have to raise less money, about, as somebody said, a $331 billion system. But in that number is long-term care. So we are anticipating coverage of long-term care. We're not going to cover $20,000 a month nursing homes, okay? I'm just be upfront. Well, I know. Because there is a tier of coverage that we simply can't afford. But in terms of your long-term care as it is now, right, for most people, we were going to be able to cover that. And then, so I think actually, and again, it's a 2-year phase-in, so we don't have all the details. This is going to be the biggest advantage of the system, I think, over time. Yeah. People not having to worry about long-term care, know that it's already covered. That's going to be huge. Yep. And so but it does take a little bit of time on that one.
And my specialists are getting paid too much, and my primary care is not getting big enough.
Your specialist is being paid too much, and your primary care isn't being paid enough. We got to equalize that, but we also got to keep the doctors. So it's a balancing act.
How will coverage take place for Californians who travel out of state or out of country and need medical assistance?
Yeah. In this sense, Healthy California functions like an insurance plan. So they would pay those claims out of state or out of country.
Whatever
for residents. Cost. Yeah, it would and that's actually true. When you go to the UK and you end up in an NHS hospital, they don't bother to bill the Americans, right? But some countries do. And we would have to. Healthy California would pay those.
I guess I'm more concerned about the out of state.
No, if you're out of state, right? Yeah. No, we would, it would be like an insurance plan.
Great.
And better because some of those insurance plans don't have, if your provider isn't in the network, right? Like, God, my Yellowstone doctor was not in my Sunnyvale network. What am I going to do?
Thank you.
This, you don't have that problem. No more narrow networks.
So one of the major ways that the federal government subsidizes the actual purchase of care is with the subsidy for employer-provided health insurance.
Yes, exactly.
So my understanding is that the trust fund there wouldn't be employer-provided health insurance anymore, which would be good because we'd guarantee universality. But presumably the federal tax rates that Californians pay would stay flat. So is there a way to recover that missing subsidy?
Yes, there is. So this is an important question because as the gentleman said, California employers and employees are getting a tax break. We don't pay payroll taxes on the cost of our insurance. That means that the federal government actually subsidizes the purchase of employer insurance to the tune of about $53 billion a year. The state of Hawaii got a waiver when it went from a system where employers bought insurance to a system where they pay taxes into a fund to cover low-income people. And they get credit for the taxes they pay. Does that sound familiar? It's exactly what we're going to do. And Hawaii got a waiver under the Obamacare, under the Affordable Care Act to do it. So we believe we will too.
With the birth of HMOs, they used co-pays as a gatekeeping function to prevent people from coming in who didn't have serious reason to be there. They also happened to weed out people who couldn't pay.
Right.
What is the best argument you have against the floodgates argument that we're likely to hear and that regulates and helps people regulate the reason to go to the doctor in the first place?
Well, the research shows that the best way to ensure appropriate utilization of healthcare is to have a strong doctor-patient relationship. So when you can go to any doctor of your choice and there's an emphasis on primary care and a system of reliable reimbursement and continuity of care, integrated care, you're going to have that kind of relationship. And when a doctor and a patient, and you talk to doctors too, they will tell you, you will be able to get the care you need because we know what that is. So in the present system, there's all these incentives to deny care because they haven't saved money in how we finance health care, right? We still have insurance companies, we still pay the premiums, we still have all that administrative waste. So we have to say, well, God, we got to save money someplace. We better make sure people use less care. Well, the Japanese go to the doctor 12 times a year. We go 4, and they're telling us we use too much health care. What's wrong with this picture? So we estimate that if you insure the people who are underinsured, who have $2,000 or more in deductible, you'll have a 15% rise in utilization by those people. And we've compensated for that in our study.
My family and I fully support the single-payer system. My first question, I have 2 questions. My first question is it, you sound confident that we can get enough money to cover the new system. I'm still a little concerned. Does the Trump administration or the Congress have any power? If they do not want to cooperate, can this system still happen?
It's, there's a lot of ways to answer that question, and I can answer it deeply in the weeds. The short answer is yes. There are a lot of ways, because no matter what they do, Californians still have a right under federal law to the Medicare and Medicaid and Affordable Care Act if they don't repeal it, and CHIP, the Children's Health Insurance Program. We still have a right to all those benefits. So no matter what system we set up, Californians who are eligible for those benefits can receive them. What we're saying is channel them through the Healthy California Trust Fund. Channel that money through a single entity. We'll pay the providers, and we'll save you money, federal government, and we will provide better access. We will provide guaranteed health care, not just insurance, not just access, but actual care. So when you say we have to do these things, we have to be budget neutral, we have to comply with federal law, and we have to improve, access, we do that. So you can't deny us the waiver. Even if they were to, there are lots of ways to take all that money and create a single channel, or set up a system to accommodate whatever provisions they want to put in. The number one problem we have at the federal government is, are they going to cut Medicaid? Are they going to take $20 billion out of California? Because they may not repeal the Affordable Care Act, but you know damn well they're going to try to give a tax break to the wealthy and take it out of our hides, right? So we have every reason to believe they're going to try to end the monies that are paid under Obamacare, and so we have to be worried about that. And here's the question for California. If they take $20 billion out of healthcare in California, how are we going to make that up? Are we going to go to all the people with insurance and say, hey, guess what? These people just lost their insurance. Can you pay higher taxes for them? They're going to say, no. I barely have health care myself. But if you say to them, hey, what about if everybody has guaranteed health care and you can go to any doctor, we can save businesses and individuals money, and yeah, we're going to have to pay some taxes because, yeah, the feds just cut $20 billion out, but everyone's going to be covered and we're still going to save money. What about that deal? And that's a much better place to be. And so that's where we think the argument lies, is ultimately California has to chart its own destiny on healthcare, not be beholden to Trump and those cronies who would, take it all away from us, and say, yeah, we have a vision for society. It's based on justice and equality, guaranteed healthcare for all. And in California, we're going to lead the nation and do it that way.
Yeah, I'm sorry, Grace. We need to wrap up, and I want to let the 2 people behind you have a chance to ask their questions. So, yeah.
I think mine's really quick. I'm with the UU Fellowship here, and we've been working with Pastor Ron and was trying to come up with a time. Prior to hearing tonight, I had heard about a film, Now is the Time, Medicare for All, but I wasn't sure, based on what's happening here in California, if that helps to educate people about the issue and everything, or are we already sort of past that? I mean, my thought was, we should get it because we want to help educate people about what's going on. Are you or anybody here familiar with that particular film? And so is that also a good educational piece for people?
I am familiar with the film, and the number of nurses in it and other advocates. I tend to think that it's not as relevant for California, my personal view, because it speaks to a federal program, and the analysis, the economist that's on there has done the federal stuff. And so I tend to think that what we ought to do in California is focus on what we can win here, which is 562.
Right.
And, so
and that's why I'm saying before I came tonight, I was thinking
I tend
that.
to think we need to do more deep education on this plan and what we need to do in California. I tend to think now is the time speaks to advocates, right? The film Fix It tends to speak to more skeptics, right, from the business side. It's more traditional in its approach and in its demographics, but it does try to address the perspective of business and from a point of view of not convinced. So I kind of like that film because it takes that stance. But advocates sometimes have a problem with that film because it is oriented to business and stuff, right? And it kind of reads that way. So, I mean, that's my take on it for what it's worth. Fix It.
No, I thought there was one other.
Oh, no, Now is the Time and Fix It are the two.
I have a suggestion. How about the one that's coming out of this meeting right here?
Yeah. Well, I was going to talk to them about getting a speaker, yeah.
I have a quick question and comment. What about medical records? Is this part of that?
Yeah, so here's the thing. Electronic medical records, my doctor left medicine, my endocrinologist left medicine because he didn't want to deal with electronic medical records. I mean, this guy's old school. He's bringing out his paper, file. So yeah, it's an issue. Kaiser spent $11 billion on their electronic medical record system statewide after wasting $1.5 billion. When you're a patient that goes from north to south, your southern doctor can't get your records from the north. There are these electronic medical record systems that Sutter and other places. You ever been in the doctor's office where they're just typing to the computer and, what's that again? So we want to get away from all that. So what the bill says is we're not going to mandate electronic medical records, but we recognize we're going to need to collect the data about utilization, and patients are going to want to be able to have their records go between doctors, right, when they change doctors. So it's a big item that we haven't figured out because we know what the pitfalls are in the present system, and we don't want to commit. Like, if we put in the bill, we're going to establish an electronic medical record system, that could be a $20 billion number, right? Just if we put that language in the bill. Mm-hmm. So we're very cautious. That's how I'll say. Recognize the need, but cautious.
Yeah.
Is this on? Now it's on. I just wanted to, this is so obvious, but imagine being a doctor and you don't have to deal with the insurance companies. You don't have to spend extra hours, filling out the paperwork. Think of the time they can spend with their patients.
Exactly.
Think of the attractiveness to other doctors from other states that really want to practice medicine. Think about how happy their patients will be and how much preventive care they will get so that they will be so much healthier, and then the doctors can be so much more effective. So I think the effects are profound, and it's just amazing what you're doing, so thank you so much.
You're here.
Yeah, thank you, Bev. That's a wonderful note to end on. I want to thank Mr. Lighty so much. We're so honored to have his expertise here tonight. Let's give him a big hand.